Yeah, 3-ish paragraphs.
Are you kidding with Mego?
We're kidding about my bio length. I'm begging them to cut it down.
And I told
ask-
Mego that I did.
Yeah. I was going to say, you could ask me. I'd cut it to shreds. No.
I have to admit, I was actually very impressed. I've known Mego for at least 2 years, and I didn't know the credentials and degrees that she has. So thank you for including that.
Oh,
hi, Chris.
good.
Hello.
Hello, everybody. Good evening, and thank you for coming. We'll begin in about a couple of minutes. I'm just starting the YouTube live. I think it's gone live. Let me just check. It does show.
Oh, I have that. I'm ready to post that on Facebook. Let me do that.
Okay, looks like it is live.
We're on Facebook.
All right. Good evening, everyone, and Happy New Year. And thank you for joining us tonight. My name is Rovina Nimbalkar, and I'm the Executive Director at NAMI Santa Clara County. Before we begin with the presentation, I'm going to give some program updates. So all our programs have been virtual since shelter in place. That was in March 2019. It feels like a very long year. It's going to be a year very soon. Our warm line is up and running from 10 a.m. to 6 p.m. Monday through Friday via phone as well as email. Our after-hour family support is available on evenings and weekends. Support groups are all listed on our website and offered over Zoom. The family-to-family January class is starting on 18th. I think the class is full, but you might want to just call the warm line to get the most updated information. The peer-to-peer January classes are all full, but you may contact the warm line for February classes. Provided education, same. You can call the warm line for more information on the February classes. Our next FaithNet training is on January 28th at 11 a.m. Again, the warm line should be able to answer any questions. Community peer program continues to match via hospitals and self-referrals. I just want to let everybody know is that we are live streaming this presentation on our YouTube channel. So if you wish not to be seen, please disable your camera and feel free to ask questions during the presentation in the chat. Mego would be happy to answer them after the presentation is over. I know some of you have sent your questions and those will be answered as well. I now would like to invite Bev Lozoff, who's the co-president of NAMI Santa Clara County, who would like to make some announcements.
Great, thank you. The main reason for me to be speaking up this evening is to talk about our upcoming election of board officers. But I'd like to just mention a few other things before that. And in case any in the audience don't know, our virtual NAMI Walks was a great success, and we raised over $220,000. And we also held our first ever online silent auction. Thanks to everyone who participated in these events. I also wanted to mention something about our holiday gift drive, albeit very different from any other year. it's usually, it usually brings so many volunteers to the office, but obviously this year we couldn't do that. But I'd like everyone to know that gifts, 650 gifts are going to various places: hospitals, self-help centers, board and care homes, veteran centers, homeless centers, etc. The specific places will be listed in our upcoming newsletter. Oh, one other thing. We would love people to renew their membership in NAMI Santa Clara County. If you haven't done so, just a little reminder. So now for our upcoming elections. Every January, we announce our election of board officers. In accordance with our bylaws, our annual election will take place at the March 2021 general meeting. And our officers are president, 4 vice presidents, treasurer, and secretary. If anyone in this audience is interested in joining our board of directors or wishes to suggest someone, please contact me. And Rovina said she would put my email address in the chat for people to see. We will be taking nominations from the floor at our February and March general meetings as well. So it would be lovely to have some new people, express interest and come to our board, even come to our board meetings. They're open to everyone. So thank you. Oh, back to Rovina.
Thanks, Bev. And you can find our board meetings Zoom link on our website. It's available out there. Okay, so now I'm going to hand over to Kyle Galimba, who's our events and walk manager, who is going to introduce our speaker for tonight. Over to you, Kyle.
Thank you, everyone. Everyone hear me okay? I'm not muted? I'm not muted. While everyone's on the YouTube, go ahead and hit that subscribe button, hit that like button. We just broke 100 viewers just real quick. Thank you, or 100 subscribers. Thank you, everyone. Without further ado, tonight's speaker is Mego Lien, Suicide Prevention Manager of Santa Clara County's Behavioral Health Services Department. In her position, Mego manages public health efforts to prevent suicide across the county. The county's suicide prevention program was developed in 2010 in response to a cluster of suicides that took place in Palo Alto high schools. The suicide prevention program applies a community-wide preventative and public health approach to the issues of suicide. While the program targets youth, middle-aged, and older adults, the suicide prevention program, along with the Suicide Prevention Oversight Committee, also specified target populations according to annual suicide data analysis that accounts for disproportionately affected cultural groups. Previously, Mego worked at Prevention Institute, a national public health nonprofit that advocates for primary prevention and community well-being. She has several years of experience in prevention of chronic disease and injury in low and middle income countries. She has also worked as a suicide crisis line volunteer and a sexual assault counselor and advocate. Mego holds dual master degrees in public health and international relations from Columbia University and a bachelor's degree in psychology and education from Swarthmore College. Please welcome Mego Lien. Thank you.
Thank you, Kyle, for that great intro. And thank you, everyone, for joining. I know these NAMI meetings are pretty late in the evening, so I'm impressed with all of the participation. I'm just going to pull up my screen. Kyle, is that coming through? Or somebody? Can you all see the screen?
Yes, it is. It is.
Perfect. Yeah. Okay, great. So as Kyle said, I have these letters after my name. The MPH stands for a Master's in Public Health, and the MIA stands for a Master's in International Affairs. And so I think that already kind of clues you in that I bring sort of a unique perspective to this topic of suicide and mental health. I'm not a clinician, and so I don't provide direct mental health services. So I thought what I would do today is give you a little bit of a primer, talk about public health and prevention a little bit, talk about what a public health approach means, And then all of that will kind of make more sense when I share with you what we do at the county suicide prevention program, which all takes a public health approach to this topic. So here are some pictures from some of those previous jobs that Kyle was saying in my bio that kind of led me to this point. They're kind of going left to right. So on the left side, I started out working in magazine journalism. I actually wanted to be an editor when I was in college. I love writing. And I worked at these two titles, so Health Magazine and Ladies Home Journal, which is now gone. Some of you might remember it. And actually was writing about health, but I didn't have any conception about what public health really was. I kind of fell into public health because I was hired for my writing skills, essentially. And moving to that middle column of pictures, that's where the global health work came in. I got a job working on public health communications in countries like Vietnam and the Philippines, is that bottom picture there that you see. And we were really putting together public health campaigns that would encourage people not to smoke or not to start smoking or not to smoke around others or support basically tobacco control policies. So I learned everything basically from coming up in tobacco control. But at the same time, I always had this interest in mental health and also in violence and trauma prevention. So in college, I studied psychology. I kept taking volunteer opportunities like on the suicide hotline in New York, and then as a sexual assault counselor up in San Mateo. And so I started being interested in how to bring these different interests together. And how you can really apply the public health approach to mental health and violence prevention and injury prevention. And so this job that I have now with the county really is fantastic because it brings together all of these different experiences that I've had, and I'm able to every day kind of put all of this stuff into practice. And it's really dynamic and really engaging. So some foundations of public health. So first of all, what is public health? And I have a few questions and interactive bits in this presentation. Maybe it would be best if people just type their answers into the chat. What comes to mind when people think about public health? And let me just try and find my chat box while people type it in. Chat, or you can unmute and just talk too, if that's easier. Any thoughts? Okay, here we go. So Kyle's saying medical conditions that can affect more than one people, relates to people's health policies for everyone, health access, and prevention of disease. Yes, all of these are great. Sorry, I'm having a little bit of technical issues here. Let me just bring this up. Okay. Great, so thank you for putting in some of your thoughts. So yes, I've had a lot of experience trying to explain people in a quick way, like I meet them at a party or something about what I do. And this one seems to be the most quick way of describing public health, where through analogy. So if a doctor is here to treat an individual, then just basically public health is around to treat the health of an entire population. And so where medicine is more kind of rooted in biology and how an individual body works, public health is more rooted in how a population or a big group's health is affected by things like people's behavior, what's in their environment or society. And as somebody said, there's a really big emphasis on how to prevent injury and illness and death before they occur. So this whole science of prevention is exactly that. There's so much research dedicated to how do you prevent things. And this is one of the frameworks that are commonly used for prevention, where Researchers and practitioners kind of divide it into 3 different types of prevention. They all have different names. So you can see here, there's primary prevention or promotion. And this is kind of strategies that affect all people, and they're universal. And you're really trying to do things that take place before an illness or an injury takes place or happens. Then you have secondary or intervention or treatment, depending on what you want to call it. And these are really strategies that are for more groups, smaller groups and targeted groups that might be at higher risk for a particular illness or injury. And then lastly, you have tertiary, or in the suicide prevention field, it's called postvention. And this would be treatment for people who've fallen ill already, or in the case of suicide prevention, it's treatment and supports for survivors of suicide loss. And so at the Suicide Prevention Program, we do a little bit of each of these different types of prevention. But in public health, really, it's primary prevention, this first one, that gets a lot of the emphasis. And there's a lot of different reasons for that. And so I'm gonna I'd like to show this quick, I think it's about 2-minute video it has music and then just subtitles that you would read. But it really kind of gets across this idea about why primary prevention and prevention are so important. So let me just make sure I can share my sound. Okay, and then I'll play. Oops, sorry. So that's the story, kind of like the analogy about working upstream. And so when you work in public health and prevention, you'll often hear, we need to go upstream. What are kind of these upstream measures? And so we're always kind of looking for strategies that are similar to like that building of the fence that these village people did, where we can prevent things from happening before people fall into the river and go downstream. Okay, so there's also financial reasons why public health and primary prevention are so important, in case you haven't been convinced yet. So on the left-hand side, this chart here is showing different factors that influence our health. So you can see there's our behaviors, what we do on a daily basis. There's what's in our environment, there's genetics, and then there's access to care. And public health really looks at the environment factors and the health behaviors. So that's really at the essence of prevention kind of strategies. In spite of this, in spite of health behaviors and the environment representing about 70% of our health, as opposed to genetics and access to care, the spending, this is from 2007 in our country, so this is dated, but the spending relatively for prevention is quite low at 4%, versus the 96% in our healthcare system that we spend on actually treating things that have already happened. And here in the middle, you can see these big numbers are essentially showing the potential savings that could come from just a 5% change in the incidence of different illnesses, injuries, and exposures. So if these things did not happen, this is the large amount of money that our country could save in healthcare costs. Under the Obama administration, the Affordable Care Act did help to increase funding for public health and prevention. They started this Prevention and Public Health Fund. But this chart from the American Public Health Association is just showing that large chunks of those funds have been kind of taken away slowly year after year. So we're constantly fighting in public health for more funding for prevention, which we know is highly cost effective when it's compared to medical treatment. This is a kind of a fun thing that we used to do at one of my old jobs at Prevention Institute, and it's just a framework of how to think about prevention. So it's called Take 2 Steps to Prevention, where you start from a particular illness and injury, and you take one step and think, okay, so what are some of the exposures in the environment or some of the behaviors that a person would do that would make that illness or injury more likely to take place? And then from there, you take a second step, and this is the one that a lot of people don't do, to take the second step from those behaviors to the environment and to think about what are the things in the environment, whether it's a policy environment or the media or a social environment, what are those aspects that are kind of making those certain exposures and behaviors more likely to occur? There's a question about breastfeeding in the category of DUI and heart disease. Let's see up here. Yeah, I think this one is if breastfeeding took place, about changes and savings that could occur. Okay, so one example about these 2 steps to prevention would be a classic one of tobacco control or smoking. So if we look at the illness of lung disease, we know now there's been lots of research and proven now that there's a very strong association between smoking as that behavior and it causing lung disease. But if we do the second step to prevention, then I'm going to ask you to type kind of your ideas into the chat again. Going from smoking to the environment, what are some of the things in the environment that might make smoking more likely to take place? I promise I'm going to get into suicide prevention, Manisha. I'm just laying the foundation right now. Actually, I'm about 2 slides away from suicide prevention. People smoking in public, okay, more stress. Movies glorifying smoking, drinking in the bars, great. So advertising, thank you, Vic. Lack of opportunity, great. So smoking is a good, easy one because we're really familiar with the different things that people have done for smoking, for tobacco control. So yes, this is, these are examples of environmental things that would be important to take action on in a public health approach. Okay, last one on prevention. So what does health have to do with it? So I'm going to show you these 4 pictures, and again, just type into the chat. What are some of the things that, these are kind of like things that you might see in the environment, but what are the health connections between any of these pictures that you see? What does health have to do with, yeah, anything that you see here? Right, okay, seatbelts save lives. So the one up on the upper right, yes. Thank you, Lisa or Ed. And some of you will remember that, we didn't have seatbelt laws for a long time. And so that kind of policy was important for helping to prevent road injuries. Fat content of food. So if you see here, the calories here are posted, and that's something that we didn't always have. So this was a deliberate public health measure to get us to think a little bit more about the choices that we're making with food. Hungry for fast food now. I get that a lot with this. Yeah, and for the playground one, that one's interesting. So people said bark chips for safety. Playgrounds are definitely a public safety measure for sure, but playgrounds and safe green spaces are actually quite, they're good not only for public safety, but and also obesity prevention and physical activity, but also good for mental health as well, as we all kind of know, getting outside and getting fresh air. And then the last one, cigarettes have become expensive due to taxes, yes. And that is a measure to kind of reduce the availability of cigarettes. All right, thank you. So last kind of public health model here, this is the socio-ecological model. And the theory behind this model is that we as individuals, we don't exist in a vacuum, and that our behaviors are all influenced by the surrounding environment, which consists of these different levels, our relationships, and then each of these levels operates within itself, and it's also influenced by the next level. And then on the right side here in mental health, the equivalent is kind of the, you might have heard of the biopsychosocial model. And so you can see these three different spheres, biological, psychological, social, and environmental, that all kind of interact and influence our mental health. And so you'll know that, you know, psychologists and therapists really focus largely on this psychological sphere. Psychiatrists and doctors really focus on this biological and psychological sphere. And then that really leaves public health to address this social and environmental sphere. And then of course, there's multiple overlap areas here. So it of course requires us all to collaborate very closely. So that gets us then to suicide prevention. And as I said, I promise all of this stuff connects and makes sense. So for preventing suicide, this is from the American Foundation for Suicide Prevention. You can see it's a combination of factors at these different levels that influence our health, and those different biopsychosocial levels that increase the risk for suicide. So you have these biological health factors here, mental health conditions, traumatic brain injury, but then also these environmental factors that have to do with relationships like prolonged stress, experiences of trauma, stressful life events, but then also things in the environment that we might see. So exposure to another person's suicide, if this could be through the media, for example, and then access to lethal means in our surroundings. And the suicide prevention program really focuses quite a bit on environmental factors. On the flip side, we also focus not just on risk and what increases our risk for suicide, but also protective factors too, which are very important as well. And so these are the major protective factors for suicide, according to the Suicide Prevention Resource Center. And our program also looks to increase these protective factors. So especially these first two of getting people access to effective behavioral health care, and then also this connectedness piece to individuals, families, community, and social institutions. Okay, so that brings me to the suicide prevention program in Santa Clara County. So most of you don't need to get this refresher on the county, but a lot of times in presentations, I just like to remind people that we're Palo Alto to the north, and then we go all the way down to Gilroy in the south. So we're a very diverse county. Population's almost about 2 million as of 2019. And we have a very diverse racial and ethnic population with almost 40% Asian, 30% white, and 25% Hispanic Latinx. I think when Kyle read my bio, he shared that the suicide prevention program was created in 2009 and 2010. And this was in response from the community to a cluster of suicides, of youth suicides in the high schools in Palo Alto. And there's a lot of members on this call today too who were part of that original planning committee and are still involved with the suicide prevention program today. I think there's a picture of one of them now. Okay, yeah, here we go. So there's Mego Lien leading the strategic planning process for the suicide prevention program about 10 years ago now. And so I was not around at that time, and Vic, feel free to jump in by chat or otherwise. But at that time, the community came together and put together a committee with a range of participants that represented different services and reflected the diversity of the county. And they met over a course of about 6 months very intensively, and they produced, I think, one of the first, if not the first, strategic plan in the state for suicide prevention, and had that authorized by the County Board of Supervisors. They included a lot of public input. You can see some pictures here of the working sessions that they had. The funding for the program comes from the State Mental Health Services Act, Prevention and Early Intervention Funds. This is Prop 63, which is the 1% tax on millionaires that funds a lot of different county mental health services. And at that time, once they had the plan, they did a lot around communications and to get the word out about this plan. What you see on the right-hand side here are 5 of the plan's very general recommendations. And you can see they're all kind of rooted in these public health interventions. They're very general in terms of, implementing and coordinating intervention programs and services, implementing community education and information, working on local communication best practices with the media, implementing policies, and then establishing data collection and monitoring. And so this was in around 2009. These are just a few of the milestones that took place in terms of the program coming together and all of the infrastructure. Staff was hired in 2010. And out of each of those 5 recommendations I just read, different work groups came together, as well as the Suicide Prevention Oversight Committee, which oversees the work of all of the work groups and the program. So they first started meeting in 2011 and then started meeting from there. In 2017, we added a South County Suicide Prevention Work Group, so they're still meeting. And then in 2018, we did a process evaluation of the program. In terms of staffing, this is what the program looks like today. We have 4 full-time staff, sometimes interns. We have a volunteer outreach program of about 10 volunteers that is run by Evelyn Quintanilla, the community outreach specialist. Jasmine Lopez oversees kind of our youth-based work and our trainings. And then Jay Donahue oversees communications and our older adults work. And then, as I said, we have the Oversight Committee as well as these different work groups working on different aspects of the strategic plan. And then it's been great that we've had some regional task forces crop up in different cities around the county. And they've been really great partners in terms of expanding the suicide prevention work and kind of deepening the roots into different cities. So the South County Work Group that I mentioned, there's another in Milpitas, and then Project Safety Net in Palo Alto. This chart that you see here are basically the 5 main objectives that we have. I'm just seeing in the chat, thank you, Vic, it's the #2 plan, I think he is saying in the state in terms of the strategic plan. These are the 5 outcome objectives that our program works towards. And going back to those public health frameworks that I was sharing earlier, they're kind of organized by the 3 levels of prevention. So the 3 at the bottom here are all primary prevention, reducing access to lethal means, improving messaging in the media, and creating supportive community environments. Then this is more secondary, increasing use of mental health services. And at the top, we work with mostly schools right now to strengthen suicide prevention and crisis response systems. So I'll go through and share some examples now of the different activities that we have for each of these objectives. For our school-based work, again, we really like pyramids. And so with the educators too, they also have this pyramid of 3 tiers that again are the 3 different levels of prevention within a school system. And when we're talking about suicide, there are trainings for each of these different tiers. So we have a partnership with about half of the school districts right now in the county. And the districts start in tiers 2 and tiers 3. They have all of their staff trained in the first year in this. Most of them are using this particular training, which is online, called Cognito. And it's really kind of an online simulation where you pretend to be the teacher, and it guides you through a conversation on how to support a student who's in some kind of psychological distress. So we really want all the teachers and staff within a school system to be able to have that support and referring kind of capability. And so we make sure that that training is in place. At the same time, we work with the administrators in each district and schools to look at whether they have crisis response teams at the school site, district level. So do you have a team of wellness people who are ready to accept referrals from students? If there is a suicidal on campus. So we'd like for every school to have a crisis response team as well as be communicating with the district. And this work is really done through the HERD Alliance. They have developed this toolkit, this K through 12 mental health toolkit for mental health and suicide prevention that includes a lot of best practice forms for school-based suicide prevention. And I think I saw Mary O'Jackie on this call. She's a member of the HERD Alliance and has been really involved in this school-based work. From there, once we've kind of done this tier 2 and tier 3 work, we move down to tier 1 and we start doing trainings with parents on mental health and suicide prevention, and then students as well. And we also look at things like how do you get social emotional learning into school curricula and into school systems. The whole idea of this is once we start training students, especially, we expect that there's going to be more identification of students who may be struggling. And so we want to make sure first that the teachers and the crisis response teams are all ready to go and can accept an increase in referrals. We take a lot of data at our program, and so this is just one example from all of those staff taking the Cognito training. They were reporting that as a result of this simulation, there have been noticeable changes in things like the number of students they've recognized as exhibiting signs of psychological distress, students they've actually approached and then talked to about support services. And the one that we saw the biggest kind of increase in reported by teachers in middle school and high school were conversations that they had had with teachers or other staff regarding students that they were concerned about. So kind of indicating that there's been more troubleshooting among the adult support staff and the teachers about students that they had concerns about. One of the questions that was submitted for the presentation was what's an easy way to get training in suicide prevention? And our program offers a whole lot of different trainings, both in mental health, which you see on the left side in the green, and also in suicide prevention helper trainings, which is the blue on the right side. And so this is we call our training spectrum. The trainings are organized from most basic to most advanced. Most of them are being offered virtually or have some kind of online version right now. And so you can, we'd be happy to, work with you if you'd like to take a training yourself or set up a training for a group of any kind. You can contact Jasmine Lopez, who is on my team, or contact me. I'll leave my information after this training, after this presentation. This one particular training is a new one that we've been working on with Palo Alto University. It's called Be Sensitive, Be Brave. And we have a version for mental health and a version for suicide prevention. And the idea is we are creating our own kind of tailored introductory community trainings in these two topics that are rooted in research on cultural competency and suicide. And so these are also available right now. We are offering them virtually. And so again, if you're interested, please reach out. Thank you, Vic, saying that you've done QPR training for NAMI staff in the past. Fantastic. And I think Kathy was mentioning there's an online QPR training flyer that we can also share. If anybody's interested in taking that online, we have free codes for that training as well. One of the services that we kind of helped to launch through the program is Crisis Text Line for the county. And so we launched this in December 2018, and this was really launched as a way to reach more people, and especially young people, who may not have been using the suicide and crisis hotline quite as much. And we run regular social media campaigns to get the word out about this particular service. So the way that you access it, you text on your phone the word RENEW, R-E-N-E-W, I'll have it at the end, to the number 741-741. And that will help access a crisis volunteer counselor by text message. It's also 24/7 and anonymous. So in 2020, this is the chart that you see here. We had 697 conversations that took place over the county's crisis text line. This big spike that you see here was the text volume in March. This is when the first shelter in place order took place. And so we saw definitely a big increase in the text conversations in that month. And some of the top issues that are being discussed this last year were anxiety and stress. That definitely rose up to the top because of the pandemic, followed by relationship, and then depression and sadness. I included some of these texter demographics here because what we're seeing is that we seem to be reaching with crisis text lines some of the maybe more underserved populations. So the majority of our texters are youth or young adults under age 34. We have about 40% Hispanic Latinx texters, 40% white, 23% Asian, and 8% Black. We have almost half of our texters reporting that they're from the LGBTQ community. And then 18% report having ADD, ADHD, 18% report having autism, and 9% report being hard of hearing. So it seems to be kind of an effective service for our purposes in terms of increasing usage of any kind of mental health support with some of these populations. Okay, so another thing we do in the program is we aim to run 1 or 2 public awareness campaigns every year. And we really look at the data and we talk to people that we want to reach to try and understand beforehand what's the most effective messaging that, that will kind of help to reduce stigma around mental health and also increase people's likelihood to go and seek help if they are struggling with thoughts of suicide. So this is one example. This is called the Benjamin campaign, and we developed this last year to really speak to the groups of older white males who represent the largest proportion of suicide decedents in our county. And so I will play this ad so you can get a sense of what we did. Benjamin is from Santa Clara County, and he has lived experience with suicidality in his 60s, I believe. And so he was willing to talk about his experience.
I got badly injured at work. As a result of that, I lost my job. My fiance left. I had no more control over my life. I couldn't even roll over in bed, and everything hurt. I regained a sense of control by saying, I've had enough of this. I don't want to live anymore. This is the end. I saw no way out. I'm lying in bed and I'm starting to hear some music. I was absolutely mesmerized by it. It was beautiful. It opened my mind. Music was so essential to me, and I wanted to pursue it. That's when I knew I needed help. I'm tough. I'm a man, hear me roar. Find help. If I need to have my roof put on my house, I'm not going to do it myself. I call somebody who knows how to do it. You need to go to people who are dedicated to helping you. They're going to help you understand what's going on, why it's going on, and what tools you have to deal with it, and why it's important. But the why it's important is really up to you. I still deal with depression. I can feel it on a daily basis even. But the thing is now, I know what to do about it. And that's what good professional help can bring. I realized what brings me joy in life. Music, friends, going out to take a walk and feeling the sunshine. Recognizing that you have that problem, and then recognizing that you can do something about it. So you're regaining control. It's the first step.
So you can see Benjamin was really wonderful. He talks about a lot of these themes about masculinity, but still reaching out for help, wanting to gain a sense of control. And most of our campaigns have this overall purpose of trying to get more people to be willing to go out and seek help if they need it. So this campaign was on air on these different channels. It was online, YouTube, Facebook. We put some on the radio, and we had some print ads in newspapers as well. And it ran July through October in 2019. And also September, we did it again, September through November of last year. And this is the campaign website, scchope.org.
I got
here are some, again, going back to data, we look at different things to see, are these campaigns actually working and doing what we want them to do? And so we look at things like the calls to our hotline. So for the Benjamin campaign, we did see that there was an overall increase in calls to the hotline when we compared the calls from older adults in 2019, July through September, which is when the campaign was on, versus the same months in the prior year in 2018. We also look at things like website visits, and for this one we had more than 12,000 clicks onto the website for more information. So right now we have another campaign on air, and this was developed specifically in response to COVID-19 and the pandemic. So the target here are English and Spanish-speaking middle-aged men, as well as their families. It launched in December on the 21st, and it's going to be on air for 9 weeks until February 21st. And we've got it on different radio stations, on Spotify, and online. And we've also done something where you can buy ads on mobile phones if you show up in certain locations. So we've kind of bought that to make it possible whenever people go to any of the COVID testing sites around the county, a lot of grocery stores and also pharmacies and some of the unemployment offices that are still open right now. So this one is a radio campaign. I'll play you both of the radio ads. They're each about a minute long.
No guy wants to feel or look weak. That's why we don't ask for help. But being strong can be even tougher when you're dealing with a pandemic. When COVID hit, I started feeling isolated and my depression got worse. I knew that if I didn't do something different, it was going to end badly. So I talked to a buddy who got me to a website and some counseling. Now, I'm starting to feel much better. I'm still a tough guy, just one who needed a little help.
Feeling down or thinking about ending it all? These are real issues that don't just go away by themselves. Get help from a trained professional today. Call 1-800-273-8255 or visit www.scchope.org/help. That's www.scchope.org/help.
So that's the English one. It's called Tough Guy, and it's because we talked to, we did a focus group with people that we wanted to reach through this campaign, and they really said that this message about masculinity and independence would be an important one to address in the ad. I'm going to play the Spanish one, which actually is a completely different ad. The Spanish-speaking focus group that we talked to, they really thought that it was important to pull in and involve their families. And so you'll hear, even if you don't understand Spanish, you'll hear a daughter speaking about warning signs that her father was showing. The wife talks about it, and then the man's best friend also. So the whole idea is getting the family involved in seeing the warning signs and helping that person get help.
Antes mi esposo estaba lleno de vida, pero por lo del COVID perdió su trabajo. Ahora está preocupado por el dinero y discutimos todo el tiempo.
Mi mejor amigo siempre era el alma de la fiesta. Ahora no quiere ni platicar ni verme. Y está aislado de sus amigos.
Mi padre era muy extrovertido, pero desde que comenzó la pandemia ya casi no sale de su cuarto y apenas come.
Como médico, sé que estas son señales de alerta de posible suicidio. Existe ayuda y el suicidio se puede prevenir. Si sabes de alguien que está deprimido o pensando en el suicidio, busca ayuda. Llama a la Línea Nacional de Prevención del Suicidio al 1-800-273-8255 o visita www.scchope.org/ayuda.
So as I said, this campaign's currently on the air. You might hear it if you're driving around, listening to the radio. We would love help to disseminate the campaign flyers for this. And we have a survey as well that we're trying to get out to folks to see if this campaign is effective. So I can share those after this meeting, if anyone is able to help us with that.
Antes mi esposo.
Okay, in terms of reducing access to lethal means, we've mostly done work so far around gun safety, although we're starting to venture into the area of hangings, means restriction as well. So with gun safety, we are involved with basically implementing and tracking the policies that are passed. We're really interested in safe storage. If there's a gun in the house, having that safely stored at all times. And so there have been safe storage policies that have been passed by a few of the cities in the county. Sunnyvale also banned a purchase of automatic rifles for youth under 21. I think that was last year or the year before. And then I think you all probably might be aware of the gun violence restraining order. And we try to get education out there as much as possible to the community that this is an option in case they're seeing the warning signs in a loved one. People in the same household, even expanded now, I think, to teachers or psychologists can call law enforcement and make a GVRO request. And then mostly we've been doing a lot of outreach and distribution, both of resources like the one you see here for gun safety rules that includes kind of suicide warning signs and resources in it. And then we also help with distribution of free gun locks. And we partner with the county to participate in gun buyback events. We distribute to gun shops, and we've helped to put on a few gun safety summits in the community too. Safe messaging is our fourth one. And in this area, this is all based on research that I showed earlier that what is seen in the media can actually influence suicidal behavior. So you might have heard of, things like the Netflix show 13 Reasons Why, or heard about this in other ways. But there's a high volume of media, or if the media is very sensational around a suicide, there's been research kind of linking that to copycat behavior or increased suicidality in other people. So this is really the work of our communications work group. We monitor the local media weekly, and we have a media response team where we review local articles that talk about suicide, and then do a lot of outreach and education to journalists about what's called the safe messaging guidelines. We also do trainings and kind of meetings at different newsrooms to share these recommendations with them and encourage the media to adopt these recommendations. And then lastly, we have a whole objective here around building connectedness. And as of this year, we've started partnering with the Youth Community Service up in Palo Alto, and specifically their Youth Connectedness initiative. And so you can see here, it's an initiative that aims at reducing youth suicide risk by promoting protective factors, especially this connectedness, strengthened relationships, and actually providing community service and engaging with the community. They have a youth program and a parent program, and they work together very closely. They do a lot of intergenerational work, and it's all designed around what's called the Search Institute's developmental relationships framework on how to kind of strengthen relationships for youth. And so if you would like any more information about this particular program, Ashley at Youth Community Service was happy to share her email and give you more information if you'd like. So that's the last kind of overview of activity from our program. I'll just leave you with a little snapshot of the county suicide data. And so we track this on an annual basis as well. And from 2011 to 2018, what you see here in green is the county suicide count for each year, as well as the rate in this kind of teal color. And it was relatively flat for a number of years. And we even saw from 2015 to 2017, a slight decrease in the count and the rate, which we thought was remarkable, especially because the country's suicide rate was kind of slightly increasing at the same amount of time. As of the last year that we have data though, 2019, we've seen kind of I wouldn't say a spike, but it's sort of like an increase that's higher than what we've seen in prior years. And so we are concerned about that and trying to understand through the data why this happened and what kind of interventions we can put in place to address it. You'll notice too, I get this question a lot about whether suicides have increased during the pandemic. This increase was 2019, so it was entirely before the pandemic. And so we've seen early numbers of suicides during 2020. They don't seem to be significantly higher, but they do seem to be kind of matching this higher rate and count from 2019. So something was going on that we're trying to look more into, but it was happening even before the pandemic started. On the right side, this is suicide attempts. And so you have emergency department visits for attempts at the top, and then emergency department visits for ideation at the bottom here. And we've been seeing that the attempts for the years that we have data is relatively flat, but there's been an increase in ED visits for suicidality in general that seems to be driven by visits for suicidal ideation. So this is just some of the data. I've just given us kind of a snapshot of the data that we have here. We have a lot more that we use to make our programming decisions. So I'll just leave you here with some of the things that can be done if you want to get involved with us or with suicide prevention in the county in general. There's so many different resources that we'd be happy for you to share. On our website, we have all kinds of community outreach materials that talk about these different resources. For example, one of our work groups, the interventions work group, developed the My3 app, which is essentially an app you can download to have a safety plan available on your phone. And you kind of put in there the people that are in your support network. And then if you click on it, it'll go directly to that person to call them when you need it. So My 3 app is an example of a great resource, the crisis text line, and all kinds of other ones. You can help us, as I mentioned, distribute the campaign flyer and the survey, which I can share after this. Contact us if you'd like to arrange a training. I heard you talking at the beginning of organizing events already, so always happy to collaborate on organizing a panel or a screening. People are also welcome to come join one of our work groups. We have a communications work group, interventions, data, South County, and then there's also those different regional task forces that I mentioned. You can volunteer with our outreach program, and you can just simply sign up for our monthly newsletter, get information about ongoing events and how you can participate after this. So I just want to finish with acknowledgements because I'm giving this presentation today, but this is really a huge effort that involves so many different people, communities, academic partners, county-based nonprofits, and multiple county agencies. So I want to give all of these organizations a shout out. And thank you very much. I can take some questions.
Thank you so much, Mego. I do see some questions in the chat. The first one is, do you have a breakdown by mental illness and the demographics?
Is that related to suicide? I'm going to assume it's related to suicide. Yeah. And we do, but we don't tend to share that data publicly because it's very it's kind of problematic. So we get our data on suicide deaths from the medical examiner coroner's office. And every time there's a suicide death, law enforcement or the coroner completes a report. And so their aim in completing that report is really to classify the manner of death. It's not really to understand the risk factors around the suicide. And so sometimes they'll say, oh, the person I interviewed says that this person had a mental illness, says they were depressed, but it's not very reliable. Okay. And so that's the reason that we don't really share that information.
Okay, thank you. What is age adjusted?
Age adjusted is basically a statistical kind of thing because you have groups of people of different age groups that are different sizes. So they adjust it so that you can compare the effect of suicide on different groups that are different sizes. That's probably the quickest way I can explain it without doing math.
Thank you. Thank you. There is a comment by Kathy. It says QPR, which is question, persuade, refer. Online training is available to everyone in Santa Clara County. This can be done at your own pace. Anyone can save a life. And then there's a comment by Vic. The county is fortunate to have Mego. Not only she's intelligent, organized, and articulate, as you can notice, she's personable too. So that's great. I do have some other questions that had come to me when participants had registered. A lot of them probably are more therapist related, but there was one I think this is something you might be able to answer. What does ideation mean? Is it that the person likes the idea of dying but will not actually commit suicide?
Yeah, thank you for that question because there's a lot of jargon, and so I like to be reminded when I'm using too much jargon. Suicidal ideation essentially is the fancy way of that person is thinking about suicide. So it's not really more specific than that. It's simply having thoughts of suicide.
The other question was, how much greater is the risk of suicide when a person has a mental health issue?
There's a lot of debate about this, where the CDC put out some research a couple years ago, pretty recent, I think it was 2018, where they looked at suicides over a number of years, and they found a good percentage. I want to say like 40%, but don't quote me on that, were were suicides where there was not a diagnosed mental health issue at play. And so the suicide prevention field is really kind of debating that back and forth, because you might have heard the statistic that's most often cited is that 9 out of 10 people who die by suicide had a mental illness, but that's now really being called into question. It seems like there might be some cultural things at play in some cases, or in a lot of cases, you know, a precipitating event like a relationship breakup or something like that might be there. Or it could be that there's just so much underdiagnosis of mental illness, and so that number was higher than it really is.
Peer pressure. There's several other reasons too.
Right.
So the other question is, and I'm not going to answer this, but I'll just ask: what steps should parents of adult children take if their child says they're suicidal? I have a lot of calls from this type of parent who feels helpless. Like they can't do anything because their child is over 18 years.
I mean, a lot of our suicide prevention helper trainings kind of address this issue and really kind of give language around how you can talk to someone who's suicidal and kind of support them and encourage them to seek help. But these trainings also really recognize that, you know, it's a complex thing, it's a deeply personal thing, so you can't really force somebody to go get help. And sometimes it takes, you know, a number of different tries checking back in with that person, or just kind of leaving them with resources and encouraging them to use them at a later time when they need to. So there's a lot of different things that can be done, but it definitely is a tricky thing. And so I would encourage you to kind of look into those trainings too. And yeah, they might be helpful.
Okay, thank you. There's another question. Is fatal accidental overdose considered suicide?
This would get into the coroner's processes, which are very, very intricate, detailed, and complex. If they're able to say with whatever evidence that it was absolutely accidental, then it probably would not be considered a suicide and it would not show up in our data. But a lot of times, there are times when it's very unclear. It's very hard to know what a person's intent was. Was it just kind of risky behavior that kind of went too far, or was it intention for suicide?
Thank you. Does anybody have any other questions? All right. So if there are any other questions, Mego, I'll just send an email to you, and then whenever you get a chance, maybe you can answer them. But thank you. I would just like to thank you on behalf of NAMI Santa Clara County and everybody who's here for coming tonight and giving us such valuable information. We're really lucky to have you and explain and give us all this data and all this information. So thank you very much for coming on a Tuesday night. And yeah.
Thank you.
Yeah. So thank you, everybody, for coming in tonight, and we will see you next month. Bye-bye, everyone. Good night.
Thank you, Mego.
Bye, everyone.